Hello, and welcome to In Your Interest. My name is Helen Sabia, Director of Public Information for the Maryland Department of Human Resources. Today we will be discussing issues which affect life and death. Programs that are provided by the state which help people live their lives more effectively, and others which help them die with dignity. Please join us.
She calls out to the man on the street. Sir, can you help me?
There is help for thousands of people with disabilities who are homeless. If you work with an organization that helps the homeless, you should know about SSI. SSI means monthly cash payments, food stamps, and medical benefits. SSI means help for the homeless. To find out more about SSI, contact Social Security.
I just missed the 8:45 to Springfield and was starting to think running away wasn't such a great idea after all. Then I saw him. Whistle Stop Willie. Rumor had it he'd been everywhere on trains. So I asked him if he were my age again and could go any place, where he'd most like to go.
To school.
His answer sent me in a different direction and is one of the main reasons I'm graduating today.
Learning. It's the smart thing to do. From the Church of Jesus Christ of Latter-day Saints.
Welcome back to In Your Interest. My name is Helen Sabia, and I am the Director of Public Information for the Maryland Department of Human Resources. Welfare reform is not just another buzzword in the state of Maryland. 1993 began with the implementation of a brand new program called the Primary Prevention Initiative. And my two guests are here to tell us all about it. Catherine Cook, Director of Policy Administration, and Joyce Underwood, PPI Program Manager. Welcome to In Your Interest.
Thank you.
There's a lot of welfare reform going around all throughout the nation. We hear all kinds of talk about it. But philosophically, why is it important to do welfare reform now? Kathy?
Well, we're very interested in preventing long-term dependency among welfare recipients. It's something that we've really been interested in for many, many years, and I think the atmosphere is just right now to move on these. We have politicians who are ready to take some action on these issues, and people are very interested in moving forward.
It's certainly a very complicated arena when you have the federal government and state governments and local governments all interacting, trying to make the programs work. Now tell me, Joyce, you're in charge of the PPI program.
Yes, and I'm very excited about this program because we believe we're on the cutting edge in Maryland. We are focusing in on two areas that are our national attention, and that's preventive health care and education. And I don't think anyone can disagree that those are two values that most people have in common. So we're real excited, and we're doing some very exciting things with this. Our program actually asks the clients to just follow simple rules and regulations that they're doing anyway.
Now tell me, when you say clients, who are these clients we're talking about?
There are aid to families with dependent children. There are clients who participate in that program. And it only affects what we call AFDC, which is the Aid to Families with Dependent Children's program. And those individuals are asked to follow some simple rules. And they are generally things that the population is doing anyway. And as a matter of fact, over 90% of our cases in AFDC have already complied with these rules. We do have a small percentage that has not. But we have help available for those individuals to help them do what they need to do to meet the new Primary Prevention Initiative criteria.
So let's talk about that. What is it that they're supposed to do?
Well, actually, it's quite simple. They really need to, for their preschool children, get regular health checkups, which are things that normally happen for our preschool children. And for our school-age children, that they attend school regularly, at least 80% of the time, which that 80% is a standard that's set by the Department of Education, that anything below that is considered truancy. So it also is exciting because it allows state agencies to work together for a common goal.
What happens if a client doesn't take their children to the doctor or doesn't get a health checkup, Kathy?
Well, then there would be a $25 disallowance per child.
And I know that a lot of people think that this is punishment, that this is punitive, that this is somehow a terrible thing that the state is doing. What does the state feel about that?
Well, we feel, first of all, that education and health are so critical for all children that parents will want to do what they can to assure that their kids grow up healthy and their kids have a chance to get to school. We assure that every individual who we're working with has at least 6 months to meet the requirements before they would be faced with a loss of $25 in their grant. So as a person comes in to apply for our services, they are told about the new requirements, and then it's not until 6 months later that they have to provide verification that they're actually meeting them. And during that time, we offer help in the way of counseling services or problem-solving seminars if they're interested in receiving that, or if they think that they're going to have a problem meeting the requirements.
I think there are some people who would say, well, it's absolutely taken for granted that you should send your kids to school and that you should get health care. What are some of the barriers that people have? Why don't they do that? What are some of the reasons?
Well, there may be reasons that are associated with problems that the child is having in school. Perhaps there are things going on in the school arena that are affecting the ability of the child to go to school with ease. I mean, we hear this every day as we watch TV, that there are things that are happening in our school arena that are not always positive effects on our children. So these are barriers, and these are barriers for everyone, not just the population of people who receive AFDC.
Do you find that, generally speaking, that the population at large and the welfare population essentially have more or less the same behaviors as they pertain to school and health care?
I think that they probably do. We don't really have statistics on that at this point, but we will at the end of our demonstration project.
Well, it is my understanding that about 95% or 90%, isn't it? 90% of the population is meeting all the requirements. It's only 10% where there is problem, and then the chronic problems are in a much smaller percentage.
That's right. At this point, almost 90% of our clients are already meeting the requirements, and there's about, I would say, about 4% or less of the population who has had difficulty coming into compliance over a period of months.
And in a way, this allows you to identify families that are in trouble that you may not otherwise have been able to identify.
Absolutely.
What do you do then? You find that here's a family, and for some reason or another, for 6 months, that you've not been able to help them meet the requirements. So would we call that a dysfunctional family?
Well, may I just back up for a moment
Sure.
and tell you that one aspect of the program that we're very pleased about is that if a person has had a disallowance for 3 months, at that point we automatically reach out to them with one of our caseworkers. Our caseworker makes an effort to contact that family, try to find out what's going on in the family, and provide any assistance that might be needed in order to meet the requirements. So we think that if a family has gone for 3 to 6 months, as you're suggesting, without meeting the requirements and getting the health care, that there may be other serious problems in the family.
The average amount of money that someone who is on welfare receives, an aid to families with dependent children, an average family of 3, receives $359 per month.
It's now $366 as of July 1st.
As of July
Yes.
1st, $366. And when we talk about $25 being removed from that grant, it's a significant amount of money.
Absolutely.
And why do you think that it's important to have the $25 disallowance? Why can't you just say, okay, let's use it as an identification purpose, but there's no penalty?
When we effected the grants in January, there were a number of people who did not meet the health requirement to get their kids preventive health care. And we scheduled some special clinic sessions at that time to encourage them to come in and try to provide, I guess, a little additional incentive and help with getting in. And during that time, I worked at one of the clinics on a Saturday, and I believe Joyce was
Yes.
very much involved in setting up that day. And a number of the parents told us that they just didn't get around to it. They knew that the health care was important, but in their lives, I guess other things were taking priority at the time, and they just didn't get around to coming in. And then faced with the loss of the $25, they were very, very anxious to come in. We had quite an increased demand in January for preventive health care services,
Yes,
which
and-
we're pleased about.
Absolutely, and in addition to that, they were also very appreciative of the fact that we reached out to them to remind them of the importance, because they had not had a follow-through like that, because resources are short in the health facilities in order to call clients and to remind them about their appointments. I know frequently I forget my own appointment, so
It's-
it's rather natural
My
process.
HMO always gives
Yeah.
calls, you know, to make sure that you do show up. I just want to have you very briefly tell me about the success stories. I hear there are some good ones.
Yes.
Yes, there are.
There are a lot of them. Actually, we have success stories where we're getting comments back from the health field where they're indicating that they're seeing children, some children, for the first time since birth. That is just amazing. And it made us feel really good about this program, that it was working.
We're also seeing some children coming in for preventive health care now who are coming in with elevated lead levels, who will be able to have an opportunity now to get some treatment, to get some help before they start school. And we're seeing children with serious other types of problems. One child, during this special clinic day that I was sharing with you, was diagnosed as having a very serious vision problem. So serious that had he not begun to get treatment, he would really lose his vision. There's another part of the program that we haven't really shared with you yet, and that is for school-age kids and adults who get a preventive health care checkup at least once a year. There's a chance for the family to get an additional $20 per person or per child. And we feel that's a really good incentive to keep kids and adults healthy as they grow older. One lady in Allegheny County, actually, let us know that she was very interested in getting that $20, though she hadn't been to a doctor since she was pregnant years ago. And so she decided to go to her gynecologist, which does qualify for the $20. And she went, was diagnosed as having cervical cancer, fortunately in the early stages. And she was treated. Her prognosis is good now. And she wrote to tell us the program has really saved my life and given me a chance to have a future. So we are just extremely pleased.
So it's truly a life-saving program on all levels. I know you had shared with me earlier the story that several principals and teachers have told you that they're seeing parents in classrooms that they hadn't seen ever before, and that sort of interaction in the community is just bound to make a better
Absolutely,
situation.
and to say that we in Maryland are excited about this program is not enough, because we believe that the Primary Prevention Initiative program is going to bring a greater quality of life to the clients that we serve.
I know that Governor Schaefer and Secretary Colvin, the head of the Department of Human Resources, have really been very pleased and proud of the way in which you all have been implementing this program. And I want to thank both of you very, very much for joining us today.
Thank you for having us.
We'll be back in just a moment to talk about a marvelous program called Project Home, which gives hope and a place to be to people who are disabled or who are dying of AIDS.
Many Americans don't have regular health checkups, so diseases with hidden symptoms like hypertension, diabetes, and cancer may go undetected until it's too late.
My doctor says I have high blood pressure. I could have had a stroke.
Your doctor can see things you can't. If it's been more than a few years since your last physical, make an appointment today. A message from the American Osteopathic Association. Physicians concerned about your family's total well-being.
The little things you do that you think are small and few are the things that mean the most to me. So just keep giving whatever you're giving, 'cause even when you're giving just a little,
if you're doing just a little, you're helping a lot.
it helps a lot.
From the Church of Jesus Christ of Latter-day Saints.
It helps a lot.
Welcome back to In Your Interest. My name is Helen Sabia, and I am the Director of Public Information for the Maryland Department of Human Resources. My guests are Joyce Neal and Margaret Scott, supervisors for the Project Home Unit in Baltimore City. welcome. Project Home is a nationally known model. Nobody else is doing anything like this anywhere in the country. We're terrifically proud of what you're doing, but we need to know exactly what it is. Joyce, you are in charge of the chronically disabled, both mentally and physically. What does that mean?
What it means, Helen, is that we house patients who are chronically mentally ill and physically disabled, those who fit a criteria that are ready for the community and want to be in our program, since it is a voluntary program.
So it's voluntary in that they want to live in the community as opposed to an institution?
It's voluntary in that they want to be in the program or they don't want to be in the program. There's nothing that mandates the patients to be in our program. So that if the family or the community feels like they need Project Home, but we have a patient that does not want Project Home, chances are there won't be Project Home.
Okay, so this is something that the community accepts, that people are living in houses, is that right? They're right in the neighborhoods.
They're right in the community with you and I. We have new treatments to take care of a lot of the physical and mental disabilities, so there's no need for the state institutions where they once were.
And I'll bet it's a much nicer atmosphere.
Oh yes, they do very well in our program. We have a lot of day programming, job training places for our clients, so that they're like you and I and are productive citizens in the community.
Whose homes are these?
Private citizens like you and I.
And you have a lot of people who volunteer for this?
Yes, we have a waiting list about 7 to 8 years long in Baltimore City who are wanting to help us out.
So you're looking for clients?
Yes.
You're looking for people who need this service?
Yes, we are.
Oh, that is wonderful. That is wonderful. Usually it's in reverse, so I'm delighted that we can be a part of letting people know about this. Now, Maggie, tell me, you are in charge of a very special unit as part of Project Home.
Yes.
Tell me a little bit about these patients that you have who are dying of AIDS.
Okay, in the disabled category in the Project Home definition of clients, in 1988, the AIDS population was added as a population who was disabled and needed housing services as well as case management services. Presently, we provide services to clients who are full-blown or symptomatic with the disease.
So not just HIV, it has to be full-blown AIDS?
Absolutely.
Okay.
Clients who are HIV are referred to another program within adult services, social services to adults. Consequently, that specialized population is provided services under Project Home.
Now, when you talk about people who fit criteria, what is the criteria that they need to fit in order to be part of the Project Home?
Number one, they must be 18 or over. They must have diagnosis by the physician as being symptomatic or full-blown. They must want to come into the program in that it's voluntary. And basically, they must cooperate with the social worker or program in using the services that the program offers.
Is there an income eligibility?
These services are available without regard to income.
So I could be a millionaire and I could come in and say, I want Project Home to help me.
Yes, you could come into Project Home and ask for us to help you. We could provide case management services to you. If you become eligible to pay for those services, you can individually pay for the services, but you will be providing case management services and the entire range of services that these clients receive.
Is case management, tell me what exactly case management is. What does that mean? I hear it all the time.
Okay, case management services include an assessment of the client needs, which evaluates the client's strengths, weaknesses, resources within the client family, within the community. Are there other areas, Joyce, that you can think of?
Yeah, they also the case manager who provides the case management services also is responsible for identifying and linking services that the patient or client needs They monitor it to make sure that what we're expecting is actually what the patient is getting.
So the patient receives service from an individual who monitors to make sure. What a wonderful service that is. Because oftentimes you may know that you need to go to a clinic to get a certain kind of help, but you're not sure if you're really getting what you're supposed to be getting. You just take it at face value.
And then there is the follow-up. After the client is referred to another agency, which we feel may be appropriate, and if there is further planning needed to adjust the original service plan or the original contract, the social worker and the client and the other people involved in the client care can do that. They can develop an entirely new service plan to meet the client's needs. So consequently, each service plan is individualized, and we provide a comprehensive range of services to meet the client's needs and to resolve the problems and to help the client increase the quality of life.
How many people are in the program right now, clients who are receiving service?
In the chronically mentally ill side, we have about 240 slots, most of which are filled.
Most of which are filled.
And on the age side, we have about 125 clients. However, our population is deceiving because we have a very high turnover in our population because of nursing home, hospitalizations, death of the client. So consequently, approximately every 6 months, we have a new caseload.
Whereas your caseload with the chronically mentally ill and disabled tends to stay the same, approximately.
Yeah, a lot of our clients are the original group that came out of the state hospitals back in the 1970s, early 80s.
And you continue to work with them. Yes, and this is a program which is statewide, but you represent the Baltimore City component. So on a statewide level, is there as much of a need to find clients who need the service?
I think a lot of our county counterparts are probably having waiting lists for client slots. Baltimore City is the largest, with Baltimore County coming next. But I think a lot of each county does have a project home in some form.
How are you funded?
We get state funds through the general fund, and we're capped at a certain number each year.
It seems as though with the general population growing older and staying healthier, particularly when someone has a chronic disability, I think people tended to die at a younger age years ago, and now we see people with Down syndrome, for example, living to be quite old. It used to be that they would die before they were 20, we were told, and now it's remarkable the kinds of developments that we've been able to do. But that what it means is that people are living in our communities who need a lot more help to get by than they did at one time. And you seem like you're very enthusiastic about the program. What are some of the stories that you've experienced with individuals that are particularly good?
We have seen patients that were way in the back wards of the state hospitals come out, be productive, participate in the day programs, kind of nurture other patients that come into the homes, and appear to really enjoy just being a part of life and society, which would not have happened without Project Home. They would have still been in the state hospitals, in the back wards, just sitting there doing nothing. They are productive. They're able to work. We have some patients that are in day programs where they run stores. They do a variety of things.
Is there any of the NIMBY, not in my backyard syndrome that's associated with this?
Oh yeah, we see that a lot, and the latest law for the disabled really has helped us because we don't really have to identify where these clients are in the community.
The American Disabilities Act?
Yes, that's the one.
That allows you not to identify.
Right, you don't have to single these folks out. They have a right to be wherever they want to be, just as you and I, so that the community groups don't have as much power as they once did about where we developed homes.
I see. So at one time you actually had to go to the city council or the county council and list the fact that you're going to be doing it. Now you just go. You just do your business.
Yes. Another way it would play out is if a community group was aware we wanted to develop a home, and if they didn't like it, then they would pose the opposition.
Now it's against the law for them to oppose
Sure
it.
is. Yes.
Well, that will certainly add to a lot of better living for everyone. I think it's really terrific, the work that you are doing. And especially with the AIDS population growing, and a lot of the fear that people have. There are a lot of people who, even when it's their own family members, once they know they have AIDS, they don't want to have anything to do with them. And that must leave people very lonely.
Yes, we have a lot of clients in our program who have been rejected by their family, and we are the last resort that they have. And I think one of the exciting things about our program is that we offer emergency services, and we have a grant to help clients who are in emergent situations, and we can even place clients emergently when they have no place to go.
Is there a phone number that people can call?
Sure. If you're talking about the chronically mentally ill or one of the other disabling factors other than AIDS, is 361-5032 or 5055, and they can receive an application that will be mailed right out.
Terrific. And what about the AIDS unit?
The AIDS unit intake number is 361-5069 or 361-5044.
Thank you both very much for joining us today. Maryland is leading the nation in welfare reform and in providing care for disabled members of our community. The mark of a truly great nation is how it treats those who are in greatest need, and we can be proud of being part of a great state which really cares. My name is Helen Sabia, Director of Public Information for the Maryland Department of Human Resources. Thank you for joining us for In Your Interest.